after solid organ transplantation?
Thank you, Mr. Chairman, my dear colleagues. It's a great pleasure for me to start this talk, and my topic is how to investigate a patient with acute respiratory failure when it is a solid organ transplant recipient. I have no conflict of interest to declare on this topic. So as you can see here, solid organ transplantation activity increased by 35% in France over the last 10 years. And the reasons for these results are, first, a longer life expectancy with a growing population of patients who suffer from end-stage organ failure that may benefit from transplantation. The second reason is significant improvement of the surgical procedures and the supportive care. And finally, a better knowledge of the immune response and the development of new drugs have led to the increased use of expanded criteria for both donor and recipients. So the ongoing therapeutic challenge is to achieve an effective and safe immunosuppression and to avoid unwanted toxicities. So, as reported in this recent study, we have now many drugs available that can be used in various combinations in order to prevent or to treat acute rejection. And they are highly effective. As an example, in kidney transplantation, the rate of acute rejection decreased from 25% to 5%. But the problem is we are increasing higher and higher the level of immunosuppression, and as a consequence, we are increasing higher and higher the side effects of immunosuppression. I'm going to illustrate this with some examples. So the first one in this study was conducted in order to compare different induction therapy in kidney transplant recipients at high risk for rejection. So it was designed to compare anti-thymocyte globulin and basiliximab. And the author reported that anti-thymocyte globulin was associated with a lower rate of acute rejection, but as you can see, they experienced more leukopenia, more infections, more bacterial infections, and more viral infections. In addition, one should keep in mind that when anti-thymocyte globulin are used as an induction therapy, it induces a very profound and prolonged lymphopenia. The second example is the development of ABO-incompatible transplantation. So as reported in this single-center experience, it is effective. So you can see that the rate of rejections are similar between ABO-compatible and incompatible transplantation. But those who underwent ABO-incompatible transplantation experienced more infections. And the last example is the increased use of organ transplantation for old patients. So it has been recently reported by several studies that old patients are more likely to suffer from adverse drug effects, such as medical interactions, underdosing, overdosing, severe infections, metabolic disorders, and cancer. And as reported in the study, you can look at the dark bars, the risk of infectious death increases significantly and exponentially with age. Pulmonary complications are among the most commonly reported, both infectious and non-infectious, and they contribute to significant morbidity and mortality. The diagnostic strategy should be based on both the knowledge of the current epidemiology and the accuracy of the diagnostic tools that are available. So transplantation starts at the time of surgery, and it has been reported in this prospective multicenter study that 5% of the patients who underwent surgery will experience at least one of the following postoperative pulmonary complications. They are listed here. And those who experience at least one of these complications experience a longer length of stay and a higher mortality. Transplant surgery have made some significant progress in order to decrease the rate of postoperative pulmonary complication. It is illustrated here. So it's patients undergoing liver transplantation, and those were randomized to a conservative strategy with a lower amount of transfusion, red blood cells transfusion and transfusion plasma transfusion, experience less postoperative pulmonary complications such as pleural effusion, pneumonia, or pulmonary edema. Beyond the time of surgery, transplant recipients might experience life-threatening complications that can lead to ICU admission. And it is illustrated here in kidney transplantation. So you can see that 6% of the kidney recipients will experience an acute illness that lead to ICU admission. And in half of the cases, the reason for ICU admission was acute respiratory failure. I think you all know these slides reporting the common infections encountered in solid organ transplantation, and they are classified according to different periods of times in the post-transplantation period. This is based on the concept that infectious complications occur in a predictable pattern. But in my opinion, this is not supported by the recent literature, and thinking timely, in fact, is not very useful. I will illustrate this. You can see that among kidney recipients who are admitted to the ICU, you can see that almost all of them are admitted in the late and very late transplantation period. The explanation might be that it reflects the efficacy of the development of vaccination strategy, prophylactic strategies, routine monitoring, and preemptive strategy, for example, for the treatment of cytomegalovirus infection. So I chose this study in order to illustrate what is actually pneumonia in solid organ transplantation. So it is a prospective multi-center study. It was conducted in 35 transplant centers in Italy and Spain. And as you can see, the median age was 62 years old and a very low rate of acute rejection, 5%. It reflects the current population of organ recipients. Patients were classified as having community-acquired pneumonia or healthcare-associated pneumonia and hospital-acquired pneumonia. This is the way they were investigated. So the first message is that more than half of the patients were already on antimicrobial therapy at the time they were investigated. And most of them underwent a non-invasive strategy. The blue bars reflect the number of samples that were performed, and the red bar, the number of samples that were positive. So only 35% of the patients underwent under a fiber optic bronchoscopy and the bronchoalveolar lavage. And what you can see is that the rates of positive results were similar between sputum examination, nasopharyngeal swab, and bronchoalveolar lavage. This is the pathogens that were documented in this study, and it reflects some current trends in the epidemiology. You can see first that 40% of the patients were infected by a multi-drug resistant bacteria. And the incidence of multi-drug resistant bacteria increased from 18% in the community-acquired pneumonia to almost all patients in hospital-acquired pneumonia. The second is that 20% had an opportunistic infection. It was nocardiosis, tuberculosis, and aspergillosis. And last, you can see, if you look at a viral infection, that there were only one case of pneumonia attributed to cytomegalovirus infection. Multi-drug resistant bacteria, and chiefly gram-negative bacteria, are a growing problem in solid organ transplantation. And the problem is when you have a patient with a life-threatening condition and when you have to choose the empiric first-line therapy, patients who are infected by a multi-drug resistant bacteria are more likely to receive inadequate antibiotics. And as reported in other settings, patients who receive inadequate antibiotics experience a higher mortality. So this is a very important study. It was conducted in Spain and published 15 years ago. The author investigated 200 immunocompromised patients with various underlying conditions of immunosuppression with pulmonary infiltrates, using both non-invasive strategy and invasive procedures such as bronchoscopy and bronchoalveolar lavage. So the main messages were, first, when you investigate this patient, you are able to yield a diagnosis in 81% of the cases. The second is the ability of non-invasive strategy to give a diagnosis in about 41%. The second is when you have a diagnosis, you change the treatment in half of the cases. And the most important message was that an early diagnosis was associated with a better survival. You can see that when the diagnosis was made during the first week, the mortality was 29%. When it was made after the first week, it was 71%. So the right question is not, should we perform or not a fiber optic bronchoscopy? The right question is, whatever the tools you use, do you have a diagnosis within the first week? If you choose to perform a bronchoalveolar lavage in this population, you will have a positive result. It will yield a diagnosis in half of the cases. But when you look at this, it is done among populations with various types of transplant. But you should take into account that there is a wide range between the studies, and most of these studies are observational studies, single-center, retrospective studies with no control group. Other tools have been developed, and this study, published last year, reported the accuracy of the beta-glucan. It was performed in the sera and in the bronchoalveolar lavage in order to investigate patients for the diagnosis of invasive fungal infections. Unfortunately, the author conclude that it is not a useful tool in this population, and because this biomarker suffers from a very low sensitivity, a low specificity, and a very low positive predictive value. Other biomarkers have been investigated and evaluated in 2 meta-analyses published last year for the galactomannan and molecular testing for aspergillosis infection. And there is the same problem, they lack sensitivity. And they have a low positive predictive value. So in summary about biomarkers, I think that they are useful if they are negative for their negative predictive value in order to stop or not to start an antifungal treatment. But if you have one or more positive samples, you should go on further on the investigation in order to confirm or to rule out the diagnosis of fungal infection. At the opposite, it could be useful to use both in combination. The rate of progression of pulmonary disease, as it is classified here, between acute process within 24 hours, a subacute process a few days, or a chronic process more than 1 week. And if you take this with the imaging pattern on the high-resolution computed tomography, it can be very useful. So, for example, this was a 47-year-old man. He underwent kidney transplantation 3 years ago. He had a history of 4 days of dyspnea, and he was referred to the ICU because of severe hypoxemia. You can see on the CT scan that we have a ground glass opacity. They are symmetrical, they are bilateral, and there are no pleural effusion. This patient underwent a fiber optic bronchoscopy and a bronchoalveolar lavage that yield the diagnosis of pneumocystis pneumonia. Pneumocystis pneumonia is the leading opportunistic infection reported in the transplant recipients, and it is independently associated with graft loss and death. We and others have reported an increased incidence of pneumocystis pneumonia in the most recent period. And our explanation was that it reflects the use of expanded criteria and higher levels of immunosuppression. This study was performed in France, in Besançon, and they reported some risk factors for pneumocystis pneumonia in the recent era of prophylaxis. And you can see here that there were no cases of pneumocystis pneumonia diagnosed during the prophylaxis period, and that the maximum risk seems to occur during the first year after prophylaxis discontinuation. Other risk factors have been reported, such as age, cytomegalovirus infection, and lymphopenia. So the bronchoalveolar lavage is useful to diagnose pneumocystis pneumonia, and it can yield the diagnosis, but it also gives some information on the prognosis, and it is reported here where you can see that the percentage of the neutrophil count in the bronchoalveolar lavage was correlated with hospital mortality. So other opportunistic agents are reported, and it depends on the type of transplant. The highest risk is for small bowel transplantation, but it's quite uncommon, and followed by lung transplantation. And you can see on the right side that there is a trend toward an increased incidence of the diagnosis of invasive fungal infections in these populations. Once again, I think it reflects the higher level of immunosuppression that are commonly used. The most commonly reported are invasive candidiasis, but it is unlikely to cause pneumonia, and then invasive aspergillosis and cryptococcosis. So once again, thinking timely is not really useful because you can see here the interquartile range, and they are very wide, and you can see this infection in the early post-transplantation period and several years after transplantation. The other opportunistic agents that are commonly reported are tuberculosis. So usually for tuberculosis, it occurs during the first post-transplant year by reactivation of latent tuberculosis. It is a challenging and difficult diagnosis in this population. It often requires an invasive strategy and repeated samples. And it is characterized by the very high rate of extrapulmonary disease or disseminated disease. The other commonly reported diagnosis is nocardiosis. So nocardiosis might be responsible for lung abscess and sometimes pleural effusion. And one of the messages is if you suspect nocardiosis, central nervous system imaging is mandatory because usually you can see some brain abscesses associated with the pulmonary disease. Some risk factors have been reported, such as the use of steroids, cytomegalovirus infection, and the high levels of calcineurin inhibitors. So there is also some non-infectious diagnosis, and the first one is pulmonary edema. It was nicely reported by the study conducted by Professor Antonelli and published in 2000, where this is a study conducted in order to investigate different ventilation strategies. And if you look at the diagnosis, you can see that 22% of the patients were reported as having pulmonary edema. And we conducted, 10 years later, a multi-center study in order to investigate acute respiratory failure in kidney transplantation. And if you look at our diagnosis, you can see that we have the same rate of pulmonary edema in this population, 21%. So the reason is, for kidney transplantation are likely to develop some cardiovascular events, and it depends on the graft dysfunction. As you can see here, that the occurrence of cardiovascular events increases with the decrease of the GFR and the graft function. And it also depends on the treatment that is used for induction, and it was reported in this study that the use of anti-thymocyte globulin when compared to other induction treatment was associated, adjusting for confounders, with an increased incidence of cardiovascular disease in the post-transplant period. So we have also some drug-related toxicities, and among transplant recipients, the most commonly reported is sirolimus. Usually, the clinical features of sirolimus toxicity are asthenia, weight loss, fever, and dyspnea for several weeks, but sometimes you can have some acute forms are reported with pulmonary hemorrhage. The most common radiologic findings are patchy bilateral consolidation and ground glass opacities. Sometimes you can also see some pleural effusion. Usually the bronchoalveolar lavage will report lymphocytic alveolitis and in some cases alveolar hemorrhage. The treatment is to discontinue sirolimus, and in the more severe cases, the use of steroids should be discussed. Other drugs have been reported to induce alveolar hemorrhage, and some of these drugs are used in organ transplantation, such as alemtuzumab as induction therapy, and azathioprine in maintenance therapy, and rituximab in order to prevent or to treat rejection. So my conclusion will be, when you want to investigate a transplant recipient with acute respiratory failure, you have to take both in consideration the story of transplantation, the story of the pulmonary disease, and the imaging pattern. Regarding the story of transplantation, you should know, is it a first transplantation or is it a retransplantation? What is the type of organ? What was induction therapy? What was maintenance therapy? Is there a story of acute rejection or not? What was the prophylactic strategies, and what was the vaccinations before transplantation, and did this patient have previous infections and colonizations? Then the story of the disease, and what is important, is it an acute process, is it a subacute process or chronic process, is it a community-acquired and a healthcare-associated pneumonia? And then the imaging pattern on the high-resolution computed tomography. The next step is, do you suspect this diagnosis, opportunistic infection, drug toxicity, and malignancy? If yes, I would suggest to perform a fiber optic bronchoscopy because it is very useful in this setting. If you have a diagnosis, it's good. If you don't have it, in selected cases, surgical biopsy might be considered. if you don't suspect this diagnosis, I think that you can use as a first-line investigation a non-invasive strategy using assessment of cardiac function, non-invasive samples, and if you want some biomarkers for invasive fungal infections in order to rule out them. If you have a diagnosis, it's okay. If you don't have it, you don't let the patient without a diagnosis, so you have to consider fiber optic bronchoscopy in a second time. And if you have a positive biomarker for invasive fungal infection, as I show you, it has a very low positive predictive value, so you have to go on and go further in order to confirm or not this diagnosis. And I would suggest to consider, among the investigation, to do a fiber optic bronchoscopy. Thank you very much for your attention.